We're now going to resume our questions. We're going to continue to have Ángel as our moderator. He'll be raising questions, and of course, any that come up, feel free to raise your hands. We'll bring you the mic over.
Bueno, pues como vamos a continuar.
Okay, so we're going to get back to things, and I'm not going to say we're going to conclude ideas, but we are going to carry on with how we started evolving. My son, my daughter was diagnosed with Schaaf-Yang. The next thing that you think of as a parent is there a cure? Is there not a cure? What medication is there? What new therapies are under clinical studies? What's out there already in the pharmacies? We've talked about orphan drugs, and we've more or less outlined some of the therapies and the medications. So the thing is, once they turn 2, 3, we've talked about that age, but what happens when they hit 13, 14, 15, even 16? We've noticed that particularly for girls, it's quite a difficult and uncertain time. So we're going to try and broach all those topics and see what we can glean. You don't have to ask permission to ask a question, either the speakers on the panel or the people in the audience. Just raise a hand or just go for it, just speak up. I'm just moderating, I'm just asking some guide questions. So now delving into the topic again, we've talked a bit about treatments, and one question that I have for our table, for our panel, is apart from treatments that seek to lessen the symptoms or improve quality of life, which is like oxytocin, growth hormone, controlling hypoglycemia, all of this is really important, especially the effects on the brain. In the clinical studies that are taking place both in Europe and in the United States, are there any new drugs, promising medications that might have an interesting outlook, that might be on the list, that we think, hey, looks like this might be working? Have we heard of anything? Is there any progress? I think Dr. Schaaf already mentioned that they have a strategy where they try to inhibit a protein which is producing these harmful effects. So that's my question, really. In terms of treatments, what do we have, and what can we expect to see in the next 5 to 10 years that might help us, maybe not to cure, but certainly to improve the quality of life of the patients? Thank you.
Okay, so is it on? Yeah.
No.
I don't think the microphone.
No.
The microphone is, el micrófono no está funcionando.
El de él no, este sí.
El micrófono del Dr. Schaaf.
Dr. Schaaf's microphone appears not to be working. This one on the table is working, though.
So the translation was cut off for a little bit in between, but I think I get the question. So basically, what do we have right now and what's on the horizon? I think, the one drug that we have right now for sure is recombinant growth hormone. And I would recommend for each and every family to consider that and to find a pediatric endocrinologist to talk about the possibility of using recombinant growth hormone, no matter how old your child is. And also, even if there is no growth hormone deficiency measurable in the blood, I would still consider trying it, because it may still help kind of gaining strength. The main effects of growth hormone are not just kind of growing in length and becoming taller. Even more importantly for your children, to shift adipose tissue, so fat tissue, kind of decrease the amount of fatty tissue and build muscle. And the build of extra muscle can be really helpful to your children at any age. Like in the young children, it can help them gain strength and reach their motor milestones, which we would hope helps them kind of walk earlier and kind of become independent earlier. But even at a later time point, it can still have very beneficial effects. And we've seen children who started growth hormone at the age of 12 or 13 and it increases their strength, but also their stamina and endurance. How long can they walk? How good can they kind of coordinate movements? Children who, for the first time, were able to kind of ride a bicycle and do things like that. So I would definitely recommend to consider growth hormone at any age. Then the other big drug that's discussed a lot is oxytocin. Especially the group of Maïté Torbert in France has done a lot of investigations of oxytocin in Prader-Willi syndrome, and they have published a study several years ago where they show that when they give intranasal oxytocin to babies with Prader-Willi syndrome in the newborn intensive care unit, that these kids improve their feeding and sucking skills, and they come off the tube feed earlier than if they treat it with placebo. So this is considered also right now for Schaaf-Yang syndrome, and Jen Miller, who is the best pediatric endocrinologist field, the most experienced pediatric endocrinologist in the field, she considers giving intranasal oxytocin to babies with Schaaf-Yang syndrome when they're younger than 4 months of age, and if they do have severe feeding difficulties. And she feels that it's worth a shot kind of trying to overcome the feeding difficulties. When kids are older than that, and we have like a lot of teenagers here in the room, and like some of the families have asked me if intranasal oxytocin would still be worth a shot. I don't have a good answer for that. Oxytocin does play a role in kind of social interaction, kind of building social trust, and it has been tried in multiple studies for children with autism spectrum disorder, hoping to improve the social skills of those kids. All of those big studies on autism spectrum disorder have not shown a proven benefit of the intranasal oxytocin. It could be, however, that in some subsets of autism spectrum disorder, where the genetic mutation actually causes a disruption of oxytocin metabolism or function, that it could still work even at a later time in life. But that is pure speculation at this point. I do know that a few endocrinologists in the United States have prescribed intranasal oxytocin to children with Schaaf-Yang even at an older age, because they say, well, it's not going to do any harm. There are no known kind of negative side effects of the oxytocin, and why not try? Try it for like 1 to 3 months. If you haven't seen any beneficial effect after 3 months, you can stop, but it may be worth a shot. I know that at least of like 1 or 2 families who have reported that they've seen a great effect in social interaction after the oxytocin, but it could be that it's just a placebo effect. So this is not in controlled trials, so it's just like the report. And obviously we all know that placebo effect, like for any drug, is significant. And especially when it comes to social interaction, things that we perceive that are very subjective, it's really hard to determine whether there's a true effect or not. So that's kind of like the long answer on the 2 things that are already in existence. There's other drugs, and in fact there's a lot of clinical trials going on for Prader-Willi syndrome right now, out of kind of the field of endocrinology. There's also new drug companies on the market, kind of some startups that have been present. I just came back from the FPWR meeting in Atlanta that was held in September. There were drug companies that contacted us because they have an interest in like testing their new drugs in mouse models or rat models of Schaaf-Yang syndrome, and then One, two, three. Okay. hopefully moving into clinical trials. So there may be opportunities to also participate in clinical trials soon. And I think through the Facebook group and through our connection through PILAR, this is one of the reasons why it may be important to also be present in our registry, because whenever we have a new study, this is our tool to reach back out to you, contact all of you, and find out who's eligible, to participate in a study. Now, in the longer run, when we think about curing or really kind of finding something that does not just treat one or symptom. Should I try this? This one on? Yes. So when we think about not just treating symptoms, but really kind of treating the cause of Schaaf-Yang syndrome, there are different ideas. For a long time, we thought that a gene therapy would be the best thing to do, and one way to approach a gene therapy would be to release the imprint on the maternal copy of the MAGEL2 gene. Because, like we discussed before, in each cell of our bodies we have 2 copies of MAGEL2, one coming from mom and one coming from dad. And the mutation on the dad's copy of the gene causes the Schaaf-Yang syndrome. But each child also has a maternal copy in each and every cell. And the idea was, if we were just able to release the imprint, the markings on the gene that prevent it from being expressed, maybe that would be a way to treat Schaaf-Yang syndrome. And there are actually several groups in the world kind of working on exactly that. There's one group in Australia that has been working on this. It's the group of Marnie Blewett in Melbourne in Australia. And she just received a big grant from, I think, the Australian government, 5 million or more, to continue kind of her work on that. But there's also a group in the United States that presented findings at the meeting in Atlanta, showing that in cells they can kind of release the imprint, and this can lead to expression of the gene from the maternal copy. But our most recent understanding suggests that that may actually not be enough. And why is that? It's because of the defective protein that's produced from the copy from dad that carries the mutation that leads to the truncated protein. So these groups here have shown that the truncated protein mislocalizes within the cell and kind of, is more localized in the nucleus of the cell than in the general cytoplasm of the cell, where it's supposed to be for most of the time. And there's a correlation also shown by these groups that depending on the mutation and the exact position of the truncation, it may be more severe or not. So we believe that not only do you need to bring a healthy copy into the cell, but you probably also have to get rid of the mutated version, because that, it seems, has toxic effect or unwanted effects within the cell. How do you do that? So this is a line of research that most recently we have embarked on, and we have designed what's called antisense oligonucleotides, which is specific kind of molecules of RNA that bind to the mutated copy and take it away to get rid of it. This is a fairly new strategy of treating genetic diseases, but there are a few genetic diseases where it's been shown that it's working. It has been shown in animal models of Angelman syndrome, for example, and it is a strategy that's also used for spinal muscular atrophy in a different manner, but kind of the same concept, that you design these oligonucleotides to interfere with what's not wanted or to overcome certain things. So we're testing this right now in cell models of the MAGEL2 rats and mice. We will, like if it works in a cellular model, we will inject those molecules into the brains of the rats to see if we can rescue, and then ultimately we would hope that we can bring it into human studies. We don't know yet how we would do that. Currently, these are actual injections into the CNS, into the central nervous system, so that it gets into the brain and can do its function there. There are also new strategies where maybe we can overcome that injection into the central nervous system, but this is still kind of many years ahead of us. Sorry, it's been a long answer.
Hola, una pregunta para el Dr. Schaaf. En relación a lo que ha comentado.
I have a question for Dr. Schaaf about growth hormone. Is there any proof that in adults this could continue to contribute in any way in people with Schaaf-Yang who have hormone deficit?
Like you turned this one on, but like my translation turned off. I don't know why. So I didn't hear your
No, repito.
Okay.
Repito la pregunta.
I will repeat the question. It's in relation to what you were saying about growth hormones. Do you have any knowledge or any evidence of adults with Schaaf-Yang and hormone deficit seeing any benefits in this, or would it not make sense at an adult age? And in relation to this, is there any link between the lack of growth hormone and hypoglycemia?
So it has not been studied systematically whether growth hormone at an adult age still has beneficial effects. I do know of teenagers with growth hormone treatment who've had beneficial effects, but I have not heard a lot of kind of data from actual adult individuals. I would still give it a try. There's one contraindication for growth hormone, and that is severe obstructive sleep apnea. So I know a lot of your kids do experience some degree of sleep apnea. It can be obstructive or central or a combination of both. If it's a severe obstructive sleep apnea, that may be considered a contraindication for growth hormone treatment. If it's mild or moderate, it would only warrant to monitor it closely because it could theoretically get worse. There's like one more contraindication for growth hormone, which hopefully does not apply to any of your children. But if you have cancer in your body, the growth hormone can kind of cause that cancer to grow even faster. So that would also be considered a contraindication. But if none of these two are present, then I would actually kind of give it a try and see if it works. And I would at least test it for like 3 to 6 months. If after 6 months you haven't seen any beneficial effects in regards of like strength and endurance, I would stop it, because then it's probably not worth it. Now, in regards of like the hypoglycemia, I'm not a pediatric endocrinologist, so I do not know. I think the person to prescribe growth hormone would have to be an endocrinologist, and that would also be the right person to ask. Obviously, you know, the hormonal imbalances in children with Schaaf-Yang can be very complex. It's kind of part of the nature of MAGEL2 and the condition. MAGEL2 has the highest expression in the hypothalamus in the brain, and this is the region of the brain that really controls many bodily functions of homeostasis, everything that has to be finely regulated, body temperature, eating, circadian rhythm, but also is kind of the master regulator of our hormonal system. So we see all different kinds of like severe or mild hormonal dysfunctions in children with Schaaf-Yang syndrome. there are some kids who have kind of what I would consider the worst end of the hormonal spectrum, which is pan-hypopituitarism. Some of the kids have been diagnosed with that. They have diabetes insipidus, they have difficulties regulating cortisol in their body, sex hormones can be changed, thyroid hormones can be changed, and also the hormones that regulate our blood glucose. We see it in both directions. We see hypoglycemia, which is more common in like young children. So a lot of the infants with Schaaf-Yang have experienced hypoglycemia. It could even be that some of the children passed because of unrecognized hypoglycemia. But then at an older age, there also seems to be insulin intolerance or kind of non-responsiveness to insulin and a tendency towards developing diabetes or early forms of diabetes. So both seems to be possible. But the connection between growth hormone and the hypoglycemia, I think, would be the question to ask the endocrinologist.
There is another question.
Hola. Sí, yo quería preguntar.
I wanted to ask two things. Firstly, what's the difference between growth hormone and recombinant growth hormone, as you mentioned earlier, because we're undergoing, or our son is undergoing, growth hormone treatment, but we don't know what it is exactly, what's this whole recombinant thing. And secondly, it's a bit of a more practical question. It can be that there are parents, obviously we don't have the scientific knowledge of medicine, can we know why, well, we try to help each other and we try to give each other a hand. But as parents, we have the idea that the growth hormone is positive. But then you may find cases where your endocrinologist or your practitioner will have a different idea. For instance, in our case, we asked our endocrinologist and said, hey, we hear that a lot of parents are trying to use growth hormone because they believe it can have positive impact. But our endocrinologist is not a specialist, obviously, in this disease. And so they have prescribed it because he has a growth hormone deficit. So obviously it's not subject to debates. But other parents might find that they want it to be prescribed, but the doctor doesn't agree because they believe there isn't sufficient proof, evidence to support the fact that this actually works. And both parties could be right. I think they don't have evidence, they don't have proof. And so what strategies can the parents use to persuade a doctor to apply a treatment that, let's say, is experimental, like you were saying earlier, because there isn't sufficient medical evidence to back these theories? So parents, I think, are in a very difficult situation because we're not doctors. We don't have the authority. We don't have the scientific know-how. We don't have a good way of explaining things to persuade our doctors. So what strategy would you suggest for us as parents, as, let's say, intermediaries who are the ones who are going to be dealing with the doctors, so that they can become better informed or can become more open-minded in terms of trying new things? So basically, it's an open question. How would you approach this issue? Thank you.
Thank you. So your first question, your child is treated with recombinant growth hormone. We often just say growth hormone treatment, but it is a recombinant form of growth hormone. Like in the olden days, like several decades ago, people with growth hormone deficiency were treated with growth hormone that was isolated from cadavers, so dead people. You know, their brain was collected and growth hormone was kind of isolated from like the brains of those dead people, and then that was injected into the people with growth hormone deficiency, which, as you can imagine, came with like many risks, right? Like HIV, hepatitis, other infections, Creutzfeldt-Jakob disease, like prion disorders, etc. So it's a risky thing to get a substance that's been isolated from dead bodies. Then, it was found, and the techniques were mastered to generate growth hormone in the laboratory using bacteria. And this is what's been done now. It's like produced in the lab. It's a pure form of growth hormone without any infectious risk. So that's why it's called recombinant growth hormone, because it uses kind of recombinant like DNA technology to produce it. But nobody today gets anything else than recombinant growth hormone. And then, like, towards your second question, it is very difficult, I understand. And I think, that's why we need to work together, and that's also what we are here for, to help you. Some physicians, they easily convinced and they just try it. Others, we can provide with like literature that we have generated. Like our group has written one article about the use of growth hormone in children with Schaaf-Yang syndrome. This may help. But then also, we are contacted by many families, and Pilar, can provide a letter to you where we explain what we know and why we think it's worth trying. And a lot of the physicians are then convinced to give it a shot. If not, you could switch providers and see if like another physician would be willing to give it to your child. But it's not just about the provider. Oftentimes it's also about the insurance company, because we also need. Oh, okay. So it's a little different in Spain, I guess. So Rosa and like the others can kind of add to that. But the insurance company also needs to be convinced, because like recombinant growth hormone is expensive. So you also want them to cover the cost of the treatment. But that's again, the letters that we have provided in many cases have helped.
Yes. Sí.
Yes, we have actually done this with some of you. Here in Spain, it can be that it's not just the practitioner who doesn't want to prescribe something, but when they decide to prescribe the growth hormone, the hospital's ethical committee is going to assess the situation. It's usually quite obvious because there's a deficit, there's a deficiency in growth hormone. They all get together, the panel approves it, and that's it. But because it has to go through the social security system, this is often going to depend. When there isn't a clear, evident shortage or deficiency in the growth hormone, and we're talking about orphan drugs, it's a bit more murky waters, and you might find that your practitioner might not want to, and they may have good reason not to want to, because they may be seeing a difficulty with apnea, and sometimes it's a communication issue. They might say, I don't want to give growth hormone to your son because he's got apnea, sleep apnea, and I'm worried that he might end up not waking up one day. And sometimes it's this issue with communication. They need to explain to you what the side effects might be. And sometimes it's just a lack of knowledge, where they think, I can't get through the ethical committee, or I know that my ethical committee isn't going to approve this. So apart from sending the literature, and we reach out to Pilar, she'll write letters. If you are in that situation, this is the right process. Give them the information, get the recommendation letter, which fortunately is now backed by published papers that say growth hormone can work in patients with Schaaf-Yang. And I would say that recently I was talking to Noelia. This is one of the things we've discussed, right? There are fewer and fewer families that are getting stuck at this stage, so it must be getting easier for everyone. And I think progress has been made. Now the ethical committees and endocrinologists are all more open. When they see a case of Schaaf-Yang, they read this paper, and that persuades them that this can be prescribed, and families are no longer getting stuck there. But of course, we've got the bureaucracy in Spain, and it can all be a little bit despairing, but it works. And so if there's anyone who you're finding is very reluctant, Pilar will write a recommendation letter, and she will try and push for it.
I want to highlight how important it is for you to communicate between you, because that strength is going to convince the doctor to read the literature based on references, based on the opinion of other patients. whether you can tell me later yes or no, but there's data that demonstrate this. We have proof with the growth hormone. So you need to be together and communicating. And if they say no, they must explain why. And this is very important because maybe there's a reason.
Of this one because the translation kind of keeps coming and going, so it's breaking off.
Hay un problema con el dispositivo inalámbrico de traducción.
Yeah, like one more aspect as it relates to providing evidence for growth hormone. Like we also thought about doing a clinical trial because like one could criticize the publication that we have and say, well, you know, it's not placebo-controlled data. It's just retrospective data that we provide. It would be much better to do a prospective trial of growth hormone that's placebo-controlled, blinded, but because of like the evidence that's out there and like parents talking to one another, we feel, and we've discussed this with families also, it would be very hard to even find families who would be like whose children have not yet been on growth hormone, like who would be willing to go into a placebo-controlled trial because all the information out there suggests that growth hormone does help. So why would you want to get the placebo?
No. Is it possible to make the question while he's... perdona, ¿se puede hacer la pregunta mientras...
Could we ask the question while they change the microphone? We're going to wait. I'm speaking to see if you listen. Okay, perfect. Well, I'm a bit lost now here. So to me, the doctor, the pediatrician, has never offered to me the growth hormone. I knew this due to the chat of the association. So I don't know if my boy that it's 11 needs it or doesn't need it. Because I learned about this thanks to the communications of the association. I'm completely lost. Nobody's giving me any information. Well, I mean, my doctor is not giving me any information. So I don't know. I don't know what should I do. That's why, because we know the reality, the situation that we are living in Spain, and we know not everybody has an access to the same health insurance and coverage. We did the article in which we published that guideline so that you can have that question there. Like, I have to ask my doctor if growth hormone could be interesting or useful. It's in Spanish, too. We did it basically thinking about the Spanish world and Latin American world. And it's a bit like to have this as a task, which is, I think it's very important for the patient association to have a checklist on to say, okay, let's speak this and this and this. Because it's that when we are talking about ultra rare diseases, it's your doctor has not ever seen any other case before, and that's normal. I'm sorry, but we need the microphone to translate what she's saying. Okay, so when it comes to the guideline that she mentioned, the families that are recently new to the association, they received an email with the guide, but there's in the webpage available, and if not, if you don't have it, you can just send us an email and we will resend this to you, but it's translated. It's prepared for you to give it to the doctors, and it's an amazing guide because it's also classified by age. So it can be quite orienting towards our kids to know what tests do we need in each moment.
I should add, I mean, this is not an experience that's unique to Schaaf-Yang syndrome, but like we see this in all rare and ultra-rare disorders. You are already at a point where you, as a parent, know more about the condition that 99.9% of the physicians that you will meet. And oftentimes it is you who will educate the physicians rather than them kind of coming proactively to suggest things that could help your child. It is unfortunate, but it is the reality, and it's a role that you have to accept. Sometimes you will learn from your physicians, oftentimes they will learn from you.
Vamos a dejar un momento.
So let's leave hormones aside. They are going to come back with this question from kid to teenager. I just have another question when it comes to therapies of gene edition, usually what we call genic. So this gene edition, CRISPR-Cas9 and all of the different therapies that we use. Tuesday, I think, we're going to have Luis Montoliu, which is a global expert in this treatment of gene therapy and also the albino cases specifically, but also focused on Schaaf-Yang. Maybe you can share some hints on what is this gene therapy. It's just like a magic pill that is curing you, or if there's any possibility or expectation on the horizon, like Dr. Schaaf said, of using this kind of gene therapy for this specific syndrome. On the one side, CRISPR or the CRISPR, it's one of the last ones that we know, this technique, that we are improving, the CRISPR, which is allowing us doing many things. The problem that it has is that it's addressed to not many cells in general. You cannot conduct a CRISPR of the whole body. You can just do it for a few things. There's been CRISPRs conducted in adults, but usually an option for this is, for example, cancer, hematology elements. You can take out the cell, treat the cell, and put it back. But in the case of a body that already exists, to try to change the genome of the whole body or access cells like the ones on the brain is not a very easy technique to carry out. So in this sense, what Schaaf proposed is to do the application of silencing the gene through RNA or axons. It has more sense rather than just modifying this cell. It's just briefly like that. And a question that they just did to me during the coffee break, I'm not an expert in this. They directly asked, okay, so if it's the copy of the father, the one which is wrong, and the copy of the mother which is right, could we somehow turn off the father's copy and turn on or activate the mother's copy? This is what Dr. Schaaf said. They're doing experiments to have the mother's copy active, but what we're not doing right now is turning off the father's copy, which is silencing with AESYS, with this technique that he was proposing, like the father's side at the same time as you activate the mother's side. That would be the perfect way, but we are saying that we are doing this in a person that has already been developed. It exists. If this is a problem that affects the neurodevelopment, the first stages, this has already been happening and gone. So what we are fixing is what works now. But how do we get to this point? Either you do it in the embryo or that is just past even before you can do the treatment. Okay.
It's one of the big questions that relates to many neurodevelopmental disorders. The symptoms that you see in your child right now, how much of that is damage that has been caused like during the developing of the brain, and how much is a ongoing dysfunction of the brain today? Because if it was all just the ongoing function of the brain, think of a computer. If there are no hardware issues at all, and it's just the software that's not working, you could theoretically just reboot the computer and kind of reinstall the software, and the computer would then work perfectly. However, if like a lot of the damage that you see is due to a hardware issue where the wires inside the computer are kind of misconnected, like the resetting of the computer would not kind of be a relief. And like we don't know that for Schaaf-Yang syndrome yet, like what the contribution is like neurodevelopmental and what's the ongoing kind of function of the brain. We do know that structurally, when we look at the brains, it's not a situation where the brains are like severely malformed and where we have evidence that there's a lot of kind of misconnections. But it would be fair to assume that, like, no matter what therapy we will develop, it would probably not cure the disease at a fully developed time point. We would hope that it can kind of improve many symptoms, but I think it would be an unrealistic expectation that if we have a treatment available in 5 or 10 years from now, that we would give a pill to your children and from today until like a few months later they behave normally and have no medical symptoms at all. I think that would be an unrealistic expectation.
Gracias. ¿Alguna pregunta? ¿No? Bueno, vamos a pasar, ya son...
Okay, so now the questions are a bit more specific, related to behavioral problems. Maybe it's not the best word. So sometimes they are asking how could we control their behavior, their problems when it comes to maturity problems in their CNS, turning from kids to teenagers, the sexual maturity, because there's not many cases of kids that are adults, but we are encountering some kids here that in a period of 3-5 years, they are going to undergo this hormone change and this process. And I guess for the fathers, it's just an uncertain moment, what's going to happen, if we're going to go to get better or get worse. So related to all of this, the bigger questions basically are controlling the behavior, or how can this hormone change can affect their kids, and if there's any kind of drug or medicine that could help to this self-control of aggressivity or impulsive behaviors, or this behavior that the kids have.
It's me. I think, it's a challenging question, and like the short answer would be, I don't know, right? But you realize that you see the behaviors in your children, and they kind of different, right? A lot of the kids have repetitive behaviors. They do the same things over and over again. They have certain things that make them happy, others that seem to be very disruptive to them. It seems like a lot of kids really need kind of a good routine, and if things are kind of regulated and they know what to expect, it's easier for them than if they put into a new environment where everything is kind of overwhelming. Also, a lot of kids have sensory issues, which is, can be part of autism spectrum disorder, that they have a hard time processing the sensory input and kind of filtering out the information that's not important to them. So reducing sensory input can help with your children sometimes. I've seen that some kids wear headphones, some of them actually use kind of noise cancellation headphones to kind of block the input from the outside, which helps them kind of focus better on the things that they want to do. But like generally, and you experience this with your children, but also here in the group, as we spend time together, many of your kids are very happy and very kind of engaging. They love to hug. They love to be with others. Which is wonderful to see. When puberty comes in, and this is not unique to Schaaf-Yang syndrome, but we see this in healthy children as well, right? Behavior changes. It can be overwhelming because there's new emotions. And teenagers don't know how to handle these emotions, and they have a hard time, and they become more aggressive or kind of short-tempered, and not only does it have an effect on their mood and their behavior, but it also has effects on the body, which changes, and they become stronger. And when aggression and strength come together, that's kind of like one of the real challenging kind of combinations, because that's when some of the parents feel like they're losing control, and when the kids become aggressive and they're so strong and you cannot contain them anymore. I don't think there's any good medications to treat that. It would be important to engage with psychologists or child psychiatrists if you feel like this is getting out of hand. There are some medications that can help with kind of obsessive compulsive behavior and such. There's a lot of medications that treat mood, but the challenge is that they may dampen kind of the overall kind of emotional kind of amplitude of your children, and it may just kind of make them very flat. But that's a discussion to have with the child psychiatrist. I do feel like behavioral modification is something that can help a lot of children. So like adaptive behavior therapy, which is like one of the gold standard treatments for autism spectrum disorder, is something that could be considered. And then also find ways to overcome the frustration that your kids have. I mean, a lot of kids are frustrated because they have a hard time communicating. So find alternative ways of communication, like sign language, using picture boards or assistive devices, which can decrease communication if they feel like they're getting across what they want to get across. And then sex hormones, that's like something that probably also needs to be discussed, because with kind of the flushing in of the sex hormones, also kind of sexual drive and libido kind of increase, and some of your kids may really enjoy kind of stimulating themselves, or they may become interested. I mean, I would expect they do become interested in kind of sexual kind of interaction with others. And with that, depending on the setting, like whether they're at home or whether they're at school, you may be in situations where you cannot watch your child 24 hours a day, and there may be a chance or a risk, depending on how you look at it, that your child may engage in sexual interaction with others while they're not entirely controlled. So birth control is something that really needs to be discussed in children with disabilities, teenagers with disabilities, and especially in females with the condition. I would definitely kind of discuss with the endocrinologist or the primary care physician the options of birth control. What a lot of families do is like rather than taking the pill like on a daily basis or like implanting things or doing like preventive measures that like last a lifetime, to do medications that can be given as shots that give birth control for 3 or 6 months and then need to be injected again, which is not like an ultimate solution, because if things develop well and like that person wants to maybe start a family by herself or himself later on, it's not definitive, but it also kind of takes away the burden from taking like something every day.
Thank you. We have like 5 minutes, 5 minutes more for another question. No? Yep. Yes.
Buenos días.
Good morning. I wanted to ask about the CO2. The level of CO2. Joanna has a CO2 level which is very high. So I wanted to know if there's something that could be done to reduce the levels of CO2.
Dióxido de carbono.
Carbon dioxide.
I am a physician, but obviously, like I've specialized in genetics, so like many kind of, subspecialties have like better knowledge about like certain aspects of the disease. I mean, the accumulation of CO2, I think, is present like in several children with Schaaf-Yang syndrome, and that is because of the decrease of central respiratory drive. So kind of the central nervous system kind of stimulates the body to breathe and to keep breathing. And we talked about apnea before. and I talked about the differences of obstructive apnea and central apnea. So obstructive apnea would be that in the periphery, the airway is obstructed either because of overgrowth or in your children because of hypotonia of the muscle, where kind of tissue in the back of the throat kind of obstructs the airway and decreases the airflow. But then also in Schaaf-Yang syndrome, and we also know that from like the animal models, when you take out MHL2 or you alter MHL2, you decrease the ongoing stimulation of breathing. You know, we don't need to think about breathing. You know, we're not spending time kind of thinking, oh, I need to breathe in, I need to breathe out. It's like, it's a basic function that comes from the brain that kind of produces that drive that measures O2 and CO2. And if there's too much CO2, the brain kind of increases that drive to breathe more because we need to breathe out the CO2. And if we breathe less, we maintain the CO2 in our body. And that mechanism does not seem to work as well in children with Schaaf-Yang syndrome. It's worse when they sleep, and if they have like a lot of like central sleep apnea, when they sleep, they really accumulate CO2, and also the O2 decreases, and then it's not good for the brain, and it may actually in the worst situation cause death. Like during the day, typically it's not as severe because the stimulation during the day kind of also keeps that respiratory drive going. But if that stimulation from centrally is not strong enough, then it may cause an accumulation of CO2. How best to treat it? I'm not entirely sure. You would have to like discuss with respiratory specialists, like pulmonologists. Like one way, like we know from young children, to kind of stimulate the mechanisms of breathing and to overcome a bit of that kind of central apnea, we give babies in the newborn intensive care unit caffeine, not as coffee, but as a pill, which can improve the breathing and also help them kind of breathe off the CO2. So this is very unscientific, but like it may be worth giving like an espresso shot and see if it improves. I don't know how many you have to give during the day, but talk to a respiratory specialist. Yeah.
Bueno, pues muchísimas gracias.
Well, thank you very much. So I think that the explanations and the responses have been amazing. Everything has been super clear. You've been super patient to answer all of our questions. I think that we all understood much more. I've learned so much this morning, so I want to say thank you because you have basically faced an expert committee here with us in the audience, and you've been able to reply and help all of them. So thank you so much for this session.